Well, I think that the main point is that we usually, when we write a guideline or a position paper in the European Society of Cardiology, we just mention the compounds that are recommended with different levels of evidence. And all this evidence in general has been obtained from randomized clinical trials where mainly men were enrolled. So we are extrapolating the data from these clinical trials to both sex, to both genders, And well, in general, we can say, well, probably we can accept that it can be extrapolated, but in some cases, this is not the case. And the reason why we cannot extrapolate data is because up to now, even up to 2017, women are underrepresented in randomized clinical trials. And this is very important because women, well, first of all, we have the idea that they are protected during the active sexual life. That after menopause, we know that things change quite dramatically. And we are trying to compare men and women of the same range of age. We miss the point that women live longer than men. And sometimes we, as practitioners, we said, well, they are protected. I don't take much care. This is not a problem for women. No, it's a problem for women. And we need particularly all the information related to differences in drug response to be included in clinical guidelines. If we have the evidence, they should be mentioned in the clinical guidelines and in position papers. And indeed, that's what we are not doing. I would like to say not only pharmacokinetics, well, the main point is that when we perform a clinical trial, we gave the same dose of a certain drug to men and women, and we forget something. For instance, usually women, the weight is lower. Usually we forget that women, they have a different, the renal function is lower than in men. And if we gave the same dose to men and women, the problem is that the plasma levels usually are higher in women than in men. And this can explain things as simple like the higher incidence of adverse effects in women. So when we try to compare men and women, first thing we need to look at is the dose calculated based on body weight, and the second is it's calculated according to renal function, and in most cases this is not the case. So we must remember that women are different than men just because the weight, the dose, renal function. These are the main, and we have some examples, I would like not only to concentrate on pharmacokinetics, but probably on pharmacodynamics. The responses are different. I mean, if I gave toracemide, that is a diuretic, I know that the electrolyte disturbances are more frequent in women than in men, that adverse effects are more frequent in women than in men. And this is important because because of pharmacokinetics, because of different response, the adverse effect, the incidence of adverse effect is greater in women. Women stop treatment. They do not continue with the treatment, or they do not follow my indications as general practitioner. And as a result, they are not protected against cardiovascular diseases. And this is a real problem. There is also the feeling, and this is funny because medical doctors, usually we consider that they need less strict treatment. We do not give the same advice to men than to women, and so on. So there are a lot of things that should be included in position papers and should be included in clinical guidelines. And this is not the case. And this was your first question, we need to offer to a general practitioner, to the cardiologist, all this information, because there is a misinformation. Well, first is education, second is education, and third is education. It's always the same. If we are not aware of the problem, the first thing is we need to clarify to the people that there is a problem and that there are some ways to improve. The first thing is, as we already mentioned, to include the information in clinical guidelines. The second one is for the next clinical trials. We need to, how many are women represented, or they continue to be underrepresented? Because if they are underrepresented, first thing we need to do is to include more women. Second is you perform a trial, but now separate the results between men and women. Don't give me the full result in the population. No, wait a minute. See if there are any difference between men and women. The third thing is, so it's analyze the gender differences in your final analysis of the study, and also in some studies there are some endpoints that can be specific for women. They should be also included. There's something else. We must understand that these sex gender differences should be included in the curricula. It's a matter, from the early beginning, the medical students should be aware that there are differences. They understand pretty well when they are in the School of Medicine. They understand that men and women have different physiology, that we have, and so we must understand, that this is very important, how sex can influence the pathophysiology of cardiovascular diseases. They are not the same. They are not the same. One example, heart failure with preserved ejection fraction is more frequent in women. Why? More, we need also to include and to stimulate that if there are any difference between men and women, they should be sticking the labels. We know that most drugs that were retired from the market because of adverse effects, most of the adverse effects were detected in women. So we need to include information, very easy information that can be immediately notified by the general practitioner that there is a difference between men and women with this particular compound. And any of these topics that I already mentioned to you are not accomplished. So we have a problem. We know the problem, but we need to transmit this problem and to look for solutions for these problems. So this is what I said to you, and I think that we have a lot of things that we can do. And the European Society of Cardiology, I think it's aware of the problem, but not too much. I mean, everybody says, yes, women and men are different, there are differences and blah, 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 blah. But we do not put these differences in some of our guidelines. We do not put these differences in some of precision papers. And this should be done because the main problem is that cardiovascular diseases are the first cause of death and morbidity in European women. It costs a fortune, and it's a matter of public health.